welcome back to my channel. In this long-awaited video, I'm gonna explain the types of hypersensitivity reactions with questions from AMBOSS. So let's get started. I'm gonna do a question and then explain the corresponding type of hypersensitivity. So let's read the last two lines. Usually when there's a question with pictures, I like to see the image first. So here a photograph of the rash is shown. Which of the following is the most likely explanation for this patient's skin findings? And here, as you can see, this is a typical wheal or urticaria all over her body. So it looks to me like this is a type 1 hypersensitivity reaction. We can still read the vignette. A 21-year-old woman returns to the physician's office because of an itchy rash. Being itchy supports the fact that this is urticaria that developed 2 hours after receiving an injection, which is quite rapid, and that is characteristic of type 1 reactions, as I'm going to tell you guys. This morning, she was diagnosed with uncomplicated pyelonephritis, and the physician administered an IV of ceftriaxone. So this was probably the allergen, and prescribed oral ciprofloxacin. So he's asking here, he's not asking you what type of hypersensitivity reaction that is, because obviously you know. He's asking why would it, or what's the mechanism behind wheals or urticaria, right? And that involves edema in the superficial dermis, guys. So the answer would be hyperpermeability of the superficial dermal microvasculature because of release of histamine. Now, the other answer choices are incorrect, like perivascular cutaneous polymorphonuclear infiltration. That means we have neutrophils that would be seen in type 3 hypersensitivity. Tissue damage caused by a photochemical derivative antibiotic, that would be seen with phototoxic drugs when you're exposed to the sun and you get a rash after using a drug. That is seen mainly with tetracyclines, with fluoroquinolones, not with ceftriaxone. Plus, she hasn't been exposed to the sun. C, that cytotoxic T cell destruction, that would be seen in type 4 hypersensitivity, as we're going to see. And E, IgE independent mast cell activation in subcutaneous tissue. That would be seen with pseudoallergy, guys. That is possible only if the patient got angioedema, right? That involves increased permeability in the subcutaneous tissue and deep dermis. However, here the patient has urticaria, and that happens in the superficial dermis. So there is a difference. Let me show you guys. When histamine is released, it increases vascular permeability. Here you got the skin, you got the superficial dermis, and then you got the deep dermis and subcutaneous tissue. When small vessels have increased permeability here in the superficial dermis, edema here and histamine here leads to an itchy wheal. Rather, if this happens deeper, that would lead to angioedema because it involves bigger vessels. All right, guys? So with this in mind, let's discuss type 1 hypersensitivity. Hypersensitivity reactions are classified into types 1, 2, 3, and 4, and the good mnemonic for that is A, B, C, D. A for allergy or anaphylaxis, that's for type 1. B for body, that's antibody mediated, that's type 2. C for complex, immune complex mediated, that's type 3. And D for delayed or late, and in fact this is the most delayed type, and the only one that's not antibody mediated, rather it's cell mediated, type 4 hypersensitivity. So with this in mind, let's discuss the first type that you all know, guys. Type 1 hypersensitivity involves an allergen or an antigen that you've been previously exposed to. It's very important to note that you must have been previously exposed to this antigen. Means your body knows it. Once the body is exposed to an antigen, the CD4 positive T cells recognize it on antigen presenting cells. So an antigen presenting cell is expressing it here. The CD4 T cells, now that it recognizes it, will start promoting the formation of antibodies against this antigen. What's different in allergic individuals is that these antibodies will be IgE rather than IgG or IgA. So these IgE antibodies tend to attach to mast cells and basophils. And the problem with these cells, mast cells and basophils, is that they have a lot of granules like histamine, leukotrienes, tryptase, and so many granules that increase vascular permeability and cause vasodilation. That's the problem here. Had this patient been non allergic, he would have produced IgG and nothing like this would have happened. So on re-exposure, we have an IgE on top of a mast cell or basophil. Once the allergen attaches and cross-links, right away we'll release vasoactive amines. What are vasoactive amines? These are substances that act on vessels, causing vasodilation and increased permeability. That is responsible for the edema everywhere, including the skin, causing urticaria, the itching because of irritating the nerves, the hypotension because of vasodilation, edema in the bronchi and bronchioles causes wheezing and shortness of breath. That is the problem. And this can be easily reversed, guys, with epinephrine. That would be life-saving because it counteracts the cardiovascular effects of hypotension that results from vasodilation. It counteracts the bronchoconstriction because epinephrine acts on beta receptors of the heart and bronchi, right? So that would be life-saving. However, not all cases of type 1 hypersensitivity need epinephrine. Sometimes it's simple as just an itchy rash. So this can take an antihistamine like cetirizine, non-sedating antihistamine. You can use epinephrine, that would be the gold standard. And we can also use corticosteroids. And the role for corticosteroids here, guys, is to prevent the late phase reaction, because it doesn't just stop at activation right now. What happens is that these leukotrienes and these cytokines released would later recruit more and more cells. And so in order to prevent this recruitment, we can use corticosteroids. This is the role here, prednisone, being an anti-inflammatory. Okay, done with type 1 hypersensitivity. Let's move to another question and see. Let's take a look at this question, guys, and read the last two lines first. Strength is initially 5/5 in the upper and lower extremities, but decreases to 4/5 after a few minutes of sustained resistance. It almost gave away the diagnosis, guys. Anyone who has fatigable weakness is myasthenia gravis. That's it. Sensations intact, deep tendon reflexes are normal. Which of the following best describes the pathogenesis of this patient's condition? I don't even need to read the whole vignette, but let's read it. We have a 51-year-old woman with hyperlipidemia. She's complaining of weakness for 1 month. At the end of the day, take a look, at the end of the day, she feels too fatigued to cook dinner or carry a laundry basket up the stairs. All right, she complains double vision after she reads for a long period because of fatigue of extraocular muscles. Now, what is the pathogenesis of myasthenia gravis? The first answer is the correct one. That's type 2 hypersensitivity reaction. Let's see why that is the case, guys. Anything that involves antibodies bound to the cell surface against your own cells is a type 2 hypersensitivity. We have antibodies against the acetylcholine receptors on muscle cells, leading to an attack. Now, this attack can impair muscle contraction in several ways. Either it's just blocking the effect of acetylcholine called antagonism on receptors. By simply binding to the acetylcholine receptor, we're not allowing acetylcholine to act and cause muscle contraction. So a simple block could be the cause of fatigue and impaired muscle contraction. That's one thing antibodies can do. Another thing antibodies can do is activation of NK cells. Once the antibody is here, NK cells come and attach to the FC receptor and start releasing substances that kill the muscle cell. That's another possible way. What else is that when antibodies are bound to an antigen, they activate the classical complement pathway, leading to a membrane attack complex that causes cell lysis. This is another way. Or a final way by which these cells can die would be opsonization. Once the antibodies are bound to an antigen, be it a bacteria, a virus, or even your own cell, maybe a red blood cell for instance, these are opsonized or tagged for phagocytosis. All of these are different ways by which antibodies can kill cells and prevent their action. And that's exactly what happens with type 2 hypersensitivity. It involves two cells, okay? The NK cell here, or the phagocyte, and the antigen on the other cell. The key here, guys, I want you to know is that with type 2 reactions, the antigen is fixed on the cell. It's still part of the cell. And this is very important to differentiate from type 3. With type 3, the antigen is floating around. Here, the antigen is still bound to the cell. Now, what are examples of type 2 hypersensitivity? Any autoimmune phenomena is more likely to be a type 2 hypersensitivity. Autoimmune attacks against red blood cells, called autoimmune hemolytic anemia, against red blood cells, against platelets, called ITP, immune thrombocytopenia, that's also possible. What else? Transfusion reactions like ABO incompatibility, RH incompatibility, that is also considered an autoimmune attack, right? So any form of blood cell lysis, whether red blood cell lysis, platelet lysis, even leukocytes lysis as part of SLE, all this is autoimmune type 2 hypersensitivity. What else? Other autoimmune conditions. We mentioned myasthenia, but there is also Goodpasture syndrome that involves antibodies against the basement membrane, right, of the lungs and glomerulus. And also antibodies against the skin receptors like pemphigus vulgaris, right? All these are types of are type 2 hypersensitivity reactions. Antibodies against a fixed antigen. Now let's see the other type of hypersensitivity. Okay, here we got, let's read the last two lines. A skin biopsy shows localized edema, skin necrosis, neutrophilic infiltration, and complement deposition. Once you see those two clues, guys, neutrophilic infiltration and complement deposition, this is a surefire giveaway of type 3 hypersensitivity. That's immune complex mediated. Which of the following is the most likely cause of his symptoms? We have a 4-month-old boy is brought to the physician because of a painful lesion on his right leg. Yesterday, he received all of his scheduled childhood immunizations, including the second dose of DTaP, diphtheria, tetanus, and acellular pertussis, which was administered in the right quadriceps. That's supposedly intramuscular, right? Physical exam shows a 2-centimeter ulcer with surrounding induration over the right anterolateral thigh, and a biopsy showed these. That is called an Arthus reaction, guys. It's immune complex mediated. What does that mean? Let me show you what immune complex means. An immune complex would be a set of antibodies, as you can see, that are bound to soluble antigens. The antigens here are separate from the cells, and that's what differentiates it from type 2. The antigens here are floating around, and as because we have a lot of antigens floating around, we also have a lot of antibodies that bind to them and float around. These immune complexes like to deposit in certain areas. They don't just like to float like that. They will end up in blood vessels of the skin, in blood vessels of the kidneys, in the joints. If this happens on a systemic level, it will cause something called serum sickness, right? In the skin, it causes a rash. In the kidneys, and the glomerulus will cause glomerulonephritis and proteinuria. In the joints, it will cause arthralgia. However, if this locus of immune complexes is localized under the skin in one location, intradermal location, we have a lot here, and this inflammation happens locally, that is a miniature of a serum sickness called Arthur's reaction. And that's exactly what happened in this boy after receiving his second dose. Why do they stress much on saying second dose of vaccine? Because it needs you to have been exposed to this antigen before, when he received his first dose, because we need antibodies to form, and this takes time. So this baby actually had antibodies, and once we injected in the same site again 2 months later, he had some antibodies around, so they formed immune complexes, and this activates complement and brings in neutrophils, causing inflammation. These two clues are indicative of a type 3 hypersensitivity. We mentioned serum sickness and Arthur's reaction, which looks like that. We got an ulcer and inflammation around, but there's other examples of immune complex mediated hypersensitivity like SLE. This is the main mechanism behind SLE. We have ANA, anti-nuclear antibodies against nuclear antigens. We got post-strep glomerulonephritis after streptococcal infection. We have any form of vasculitis, by the way, it's a type 3. Some types of rheumatoid, like rheumatoid arthritis, is both type 2 and 3 together. Polyarthritis nodosa, where there is a vasculitis, there's deposition everywhere. And reactive arthritis as well, that comes after chlamydia infection and other infections. That's the triad of can't see, can't pee, can't bend my knee. All these guys are examples of type 3 reaction, and a very high yield point will be HBV. Hepatitis B can also cause a serum sickness like reaction. All right, let's take a look at an example of type 4 hypersensitivity. Alright, last question, guys. Let's read the last two lines. After 48 hours, there is a palpable induration of 17 millimeters, which is obviously big. This reaction is most likely a result of which of the following substances? So it looks to me, guys, like this is a type 4 reaction, but we still need to read the vignette. A 46-year-old woman comes to the physician for a 6-month history of worsening bronchial asthma control. Before this issue began, she only used her salbutamol inhaler once a day. Now she has to use it multiple times daily and reports frequent nighttime awakening. That's real worsening of her symptoms. 7 months ago, she moved to an apartment that is damp, has mold on some of the walls. That's probably the reason why she's getting all these exacerbations. The physician injects 0.1 ml of Candida albicans extract on the midvolar surface of the right arm intradermally. And then the reaction doesn't happen now, but 48 hours later. And the reaction is not a wheel, rather an induration. Okay? So all these guys suggest this is a delayed type 4 hypersensitivity reaction. Now, what substance is released for this induration to happen? The substance would be interferon gamma. Why is that? This is a cell-mediated immune reaction, guys. Let me show you what it involves. Here, you get exposed to an antigen, which is the candida, for instance. All right? This gets presented by the macrophages on MHC2 receptors, those in brown, okay? Now, presentation on MHC2 right away brings in CD4 positive T cells. When CD4 positive T cells recognize the antigen presented by MHC2 receptors on antigen presenting cells, only the antigen presenting cells have this receptor, guys. These include macrophages, dendritic cells, Langerhans cells. Those are the antigen presenting cells. Once it recognizes it, it starts releasing two important cytokines, interferon gamma and TNF alpha. Those cytokines help the macrophages kill the antigen more effectively. Okay? They help it release more phagocytic substances. And these induce and recruit more neutrophils and macrophages on site and induce inflammation. This inflammation leads to swelling and induration, and that's what you see and palpate and measure as 70 millimeters. For this to happen, guys, it takes time, and that's why we need at least 48 hours, and that's why it's called delayed. You can see here that no antibodies are involved, so this is a purely cell-mediated reaction called delayed type hypersensitivity. This is not the only example. What this patient has just shown is a candida skin test. Now we can also do this test with another antigen like the TB skin test if this patient has been exposed to TB, right? The tuberculin skin test. Or if this patient has some sort of allergy to nickel or some whatever substance she's wearing, and this happens later, or maybe skin product, and this happens 48 hours or more later, that will be called contact dermatitis or eczema, right? Now, this is the mechanism behind graft rejection as well, guys. And this is the mechanism behind most drug reactions. When you find drug reactions that are not serum sickness, it's most likely a type 4 hypersensitivity like Steven Johnson, toxic epidermal necrolysis, all this stuff. Anything involving T cells on site. All right, guys? Hope you found this helpful. Let me know what you think. All the best.